What's up, Ninja Nerds? In this video today, we're going to be talking about intestinal ischemia. That includes a couple different diseases like acute mesenteric ischemia, which will be the primary focus, as well as the other ones that we should take a time to consider as well, which is the chronic mesenteric ischemia and ischemic colitis. This is a part of our clinical medicine section, and if you guys really are enjoying these videos, they're helping you to smash your step 2, your pants, please support us. And some of the simple ways that you can do that is by hitting the like button, commenting down in the comment section, and subscribing. Also, do something for yourself to really help you guys to understand these topics. Go down the description box below. Click on the link that goes to our website, become a member, because then you'll have access to premium notes, illustrations, quiz questions, all of these things which will help you to go through this in a repetition-based manner and really nail down these topics and cover any things that we don't actually cover maybe in this lecture. All right, let's talk a little bit about intestinal ischemia. So the first one that we'll focus on is acute mesenteric ischemia, also known as AMI sometimes. So this is a really terrible disorder. Now with acute mesenteric ischemia, when we talk about the pathophysiology, it's really just a disorder of the vessels, but leads to the undesirable complications that it has on the bowels. So we have to go back to some of our basic kind of anatomy. And so if you guys remember, here we have our aorta, right? This big kind of like vascular artery within the center of our body. Off of it, you have a couple different arteries. One of the most common arteries that is affected in patients who have acute mesenteric ischemia is going to be what's called the superior mesenteric artery. That's going to be this one right here. The other one that can also be affected, but it's much less common, is going to be this one here, which is the inferior mesenteric artery. Now, the superior mesenteric artery is supposed to supply blood to the small bowel. So this includes, think about this. This is the duodenum, the jejunum, the ileum, and on top of that, it supplies the proximal colon. So we'll even put this up here, the proximal colon, and I'll kind of highlight what that consists of. So small bowel is duodenum, jejunum, ileum. Proximal colon is cecum, ascending colon, transverse colon, and usually it'll go up to about 2/3 the way of the transverse colon before you get to that flexure, which we call the splenic flexure. All right, so it supplies a huge amount. Whereas the inferior mesenteric artery, it really just supplies the distal colon, if you think about it. And so that's going to be after or around the area of the distal 1/3 of the transverse colon as it goes into that splenic flexure where it turns down, descending colon, sigmoid colon, and then even parts of the rectum. And so this is the two things that you have to understand. By far, and I think this is the most important one to remember, this is the most common artery to be diseased. And we'll talk about the way that this artery is diseased. But I think the overall pathophysiology here is blood is supposed to move down through the aorta. It could come out via the celiac trunk. It could move via the SMA, or it could move via the IMA. But the most common one is going to be the SMA. Something in this artery is usually reducing in some way, shape, or form, or in worst case scenario, we'll use the worst case scenario, blocking off the oxygen supply. And if you block off the O2 supply to a massive part of your GIT, can you imagine the repercussions? Well, if you don't give oxygen supply, or you give very little oxygen supply to the small bowel, which is massive, and even parts of the proximal colon, this thing can start to develop ischemia. And if it becomes to the point where the ischemia starts becoming irreversible and the tissue starts dying, then we end up with infarction and necrosis and so many different terrible complications. I think one of the big things to remember is because this affects such a large part of your bowel, this is why this one is a surgical emergency. And usually patients die if not treated appropriately. So usually what will happen is they'll have profound, I'll actually kind of write this here, they'll have profound ischemia of the bowel, and this profound ischemia will lead to what we refer to is just very high yield here. Abdominal pain, I'm going to do it in red here. Abdominal pain that is out of proportion to their physical exam. What the heck does that even mean? That means that these patients will scream and writhe in abdominal pain. But when you go and perform physical exam findings, they won't exhibit the classic findings of peritonitis unless they've perfed. And so they won't have the rigidity, the guarding, the rebound tenderness, the massive pain whenever you press on their belly. They're going to be screaming and complaining of pain, but their physical exam won't suggest that. That is really high yield, and if you see this term anywhere in your clinical vignette, be thinking about reduced oxygen supply or no supply via the SMA to the small and proximal colon, leading to a profound ischemia, and if not reversed, it can lead to infarction and death of the bowel. And we'll talk about the complications of what that looks like a little bit in a second. Question then arises, what is clogging off that SMA? There's a couple different things. One is it could be due to thrombosis. Pretty straightforward. Imagine here you have an atherosclerotic plaque, so patients who have atherosclerosis, and you cause a thrombosis. So you fissure that plaque or you rupture it and then you clot off that actual plaque. If I clot off that plaque, am I going to get any blood flow to this actual small bowel, which is the most profoundly affected one? No. And so therefore, I'm going to throw off my O2 supply. So I'm going to kind of represent that with the O2 here. This guy is not getting, he's going to cut off here, and boom, there's going to be very little oxygen being supplied to this bowel. Ischemia will ensue. They'll start screaming and writhing in pain. Okay? Again, I think one of the biggest things is if you have thrombosis, it's usually a plaque that ruptures. So look in their history for a history of atherosclerosis. If they have a history of atherosclerosis, which is usually going to be remembered by that mnemonic SAD-CHF, which are risk factors, smoking, right? Increasing age, diabetes, if they have high cholesterol, particularly their LDL, hypertension, and a family history of atherosclerotic cardiovascular disease, definitely suggests it. Another thing that can clog up the SMA is embolism, and I'd say that this is going to be the one that I want you to remember, and they'll probably most likely hit you with on the exam. This means that you don't thrombose or clot off a stenosis. In this scenario, you had a clot that came from somewhere else. You probably know where that's coming from, right? It rushed into your circulation, into your systemic circulation, popped into your SMA, and now if it pops into the SMA and gets stuck in the actual SMA, are you going to be able to get oxygen to this actual bowel here? No. And so the O2 supply is going to be shut down. And if I shut down the O2 supply, this bowel will start to become ischemic, and if not reversed, it'll infarct and we'll develop some scary complications, a little writhe and pain. Embolism is by far the most common. I think the thing that you want to look for on the exam is a history of cardioembolic disorders. What's the most common one? Atrial fibrillation. So look for a history of AFib, or look for a history of do they have any underlying AAA. AAAs or aortic diseases are also really common because they can cause little, kind of like if you have an aneurysm, you can cause stasis in that aneurysm and clot that off and flip it out. So look out for any kind of AAAs as well, all right? The last one, which is an arterial disease, is actually going to be something that we refer to as hypoperfusion. They also can write this in another particular way, which is called non-occlusive. So another way that you want to remember this, sometimes they write this as what we call, just remember, NOMI. So non-occlusive mesenteric ischemia, or it's just hypoperfusion. So there's no clotting off of a stenosis and thrombosis. There's no clot that gets thrown out into the systemic circulation and blocks it off. These vessels could be healthy. But what happens is the patient is in overt shock. And so the amount of blood, if they're in shock, so they're actually not perfusing organs, if their blood pressure is terribly, terribly low, right, which is in a patient who would be in shock, then what's happening is your perfusion to the tissues is going to be reduced. And one of the tissues that is definitely going to get hit in this particular scenario, and I'm going to put this because usually it doesn't completely clot it off, but it's going to reduce it pretty good, you're going to reduce off your O2 supply, and this definitely will, again, cause ischemia to the bowel. It just won't completely lose any blood flow like you would in embolism or thrombosis. But hypoperfusion, it's usually such low BP that causes hypoperfusion of the actual bowel. The big thing that you want to look for here is a history of shock. This could be any type of shock. Is the patient in hypovolemic or hemorrhagic shock? Are they in obstructive shock? Are they in cardiogenic shock? Are they in septic shock? You're probably going to see this more likely in septic shock and in cardiogenic shock. Or, which we use to treat shock, vasopressors. Are they on super high doses of vasopressors? Because if you're on high doses of vasopressors like epinephrine, norepinephrine, things like that, guess what they do? They clamp down, they squeeze on arteries. And if you squeeze on these arteries, are you going to be able to get a lot of blood flow even if your blood pressure is really low through those? No. And so again, it'll worsen the hypoperfusion. So look, are they critically ill? If they're critically ill, think about hypoperfusion, okay? All right. The other scenario that I really want you to think about is, out of all of these, embolism is the most common. This would be second. This would be third, right? But I think when it comes to a lot of these scenarios, we think it's just the artery that's the problem that causes ischemia to the actual bowel. It's not. In some scenarios, it actually could be due to a venous occlusion. And this is actually really interesting. Most of the cases are embolism, but some of them could be venous occlusion. And what happens is sometimes you could have an occlusion of this vein right here, which is called the portal vein. And if I have an occlusion of the portal vein, what happens to the back pressure? It increases. Another one is I could have an occlusion of the superior mesenteric vein. Or I could have an occlusion of the inferior mesenteric vein. So if I have occlusions here, what happens is this causes congestion. It causes venous congestion, and it makes it really hard. So imagine you have a vein and you're supposed to be feeding this via an artery. If you can't drain the blood out of that, then the blood stays in that kind of circulation there, and it creates an opportunity, again, for reducing perfusion, reducing the blood flow across the artery into the vein, and that reduces oxygen delivery. So because of these happening, you'll cause a back pressure, and that back pressure will lead to, so you have an increase in back pressure, and this will lead to venous congestion, and this will alter the perfusion gradient. And if you alter the perfusion gradient, guess what's going to happen? You're going to alter the O2 supply. So it's kind of like a weird concept, but if you block up these veins, you're going to cause venous congestion. You're going to alter the movement of blood from the artery into the vein, which is going to alter your O2 supply. And if you really reduce your O2 supply, what do you think is going to happen? You're going to start causing this bowel to become ischemic, right? And again, I think it depends on which one is actually going to be the vein that's usually affected. Usually the most common out of these is the mesenteric veins. So there's two types of venous occlusion that can actually occur here. I'd say the more important one to remember is going to be what's called mesenteric vein thrombosis. And this is extremely common in hypercoagulable conditions or in malignancies, or in even sometimes like certain nephrotic syndromes. The other one is portal vein thrombosis. And this is more common in a patient who has cirrhosis. So if they have cirrhosis, they can get portal vein thrombi because of stasis of blood flow. You just can't get blood through there because it's such a high pressure, so it stays in the area, and you can get clots. So think about a patient who has hypercoagulable conditions or an underlying history of cirrhosis and now presents with abdominal pain out of proportion. It's just a different mechanisms to that. So again, abdominal pain out of proportion, acute mesenteric ischemia, arterial occlusion, thrombosis, embolism, hypoperfusion are the arterial causes, and then it could be a venous cause like mesenteric vein thrombosis or portal vein thrombosis. All right, with that being said, the next concept is, what about these two? the stepchilds of intestinal ischemia. There's chronic mesenteric ischemia and ischemic colitis. These ones are a lot easier. So we have a couple vessels here. So this one here is called your celiac artery. This one here is your superior mesenteric artery. And this one here is called your inferior mesenteric artery. So what happens in chronic mesenteric ischemia is that these patients have blood coming through their aorta, but the problem is they have these plaques. They have pretty profound atherosclerotic plaques within these vessels. And in order for us to truly have the diagnosis of chronic mesenteric ischemia, again, you want to look for these patients to have primarily atherosclerosis that causes at least greater than or equal to two vessels, two arterial stenosis. In other words, in order for me to truly have this disease, I need to have atherosclerosis, and particularly of these vessels. And really, in order to really solidify this diagnosis, it has to be of at least two or more of these vessels. So I have to have a plaque in the celiac and the SMA, and if I could, maybe even the IMA. Or at least, again, it's just some combination of these. I at least have to have two or more plaques within these three vessels. If that happens, the concept is that you're having a plaque that's reducing supply. I'm really reducing oxygen supply to multiple areas of the bowel. Celiac supplies a lot of the stomach and even parts of the beginning of the small intestine. The SMA supplies pretty much most of the small intestine, the proximal colon, we already talked about that, and the IMA supplies the distal colon. Again, the concept is that whenever you have a reduction in supply, here's the problem. These patients will have pain, but the pain is usually whenever they're eating. I want you to think about this. You're having a reduced supply to the gut, right? And that's going to cause decreased oxygen delivery to the cells that are involved in absorption. Now, increase the demand of those cells. So if I have reduced supply, I want you to think about this like coronary artery disease in the same concept. If I'm reducing the supply, what if by some way, shape, or form, I increase the demand? So this is, right now, reducing O2 supply. What I need to do now to make everything worse is I need to increase the demand. So how would I do that? I'm going to go ahead now and have this patient eat food. So whenever they eat food, what that's going to do is that is going to, so let's say that this patient ate some food. Whenever they eat some food, it's going to increase the oxygen demand because now you're going to have to get a lot of blood supply to this GIT so that you can absorb nutrients. And so now you've increased the O2 demand indirectly. And if you increase the O2 demand, but you're not getting enough good supply to the GIT, the combination of these two things here gives you abdominal pain. We also call this abdominal angina because it's like you're exerting yourself, but you're exerting your GIT to absorb nutrients when you're eating, and it causes pain. So oftentimes this is what we refer to as postprandial abdominal pain. And if you like that other term, you can call it abdominal angina. But it's the straightforward concept of where you have atherosclerotic plaques along multiple of these splanchnic vessels that are reducing O2 supply. If they eat food, they're going to increase their demand. The combination of these two will cause ischemia, which will lead to ischemic bowel, postprandial abdominal pain. So they'll really only develop ischemia of the bowel when they're really eating. And what happens is, what's kind of cool is you're like, oh, well, how does their bowel not die? The reason it doesn't die is that this is chronic. And so they have time to create little collateral vessels. And so they create collateral vessels to get some of the supply increased. And so that's what happens. You don't have that ability to do that in an acute scenario. In a chronic scenario, you'll generate these collaterals to kind of bypass that big old chunky plaque, okay? All right, difference between these two, postprandial abdominal pain, reduction in supply, multiple atherosclerotic plaques. Big thing is this postprandial abdominal pain. This is an acute, abrupt onset of pain out of proportion. Arterial occlusion or venous occlusion, this is just arterial stenosis. Let's come down to the last one. The last one here is ischemic colitis, and it's pretty straightforward. And this one, this is the time where the IMA is usually going to be the one that's affected here. What happens in ischemic colitis is it could be due to, arterial occlusion, but it's most often due to hypoperfusion. So it's when these patients have lower blood pressures, and I would again think about this in a patient who has a history of shock. Think about these patients if they're on high-dose vasopressors, or they're on certain medications that cause vasoconstriction, sometimes those migraine medications. It's usually these patients who have profound hypoperfusion. So we'll write this down. This is a patient who has hypoperfusion. And if you have hypoperfusion, you're not going to get the blood flow rushing through the celiac. You're not going to get blood flow via the SMA. And you're not going to get a lot of blood flow moving via the IMA. And so what happens is they have a pretty significant reduction in O2 supply. But here's where it gets a little bit tricky. The IMA, we know, supplies the distal colon, right? So it definitely supplies the distal colon. I think one thing to remember, though, is while it does supply the distal colon, there is a little bit of blood supply, right? So here's your celiac, which primarily supplies like the stomach, the liver, other parts like the pancreas and the beginning of the duodenum. And then you have your SMA. The SMA, I want to kind of put a little point over here. The SMA does give a little bit of supply here to the distal part. So imagine here the SMA will give it a little bit of supply here. The inferior mesenteric artery will give a little bit of supply here. And then it'll supply the rest of the bowel. So here's going to be the IMA. So we call this area here right at that splenic flexure. So this is the splenic flexure. We call this area where the blood supply is kind of like overlapping a little bit, the watershed area. And so what happens is in patients who have profound hypoperfusion, they're decreasing not just the IMA flow, the celiac flow and the SMA flow. The SMA will give a little bit to this distal part of the transverse colon, and the IMA will supply most of the distal part of the transverse colon as you go down to the distal kind of descending colon. Right here where they kind of overlap is the most susceptible area during hypoperfusion. And so this is the area that'll start to become ischemic. This area right here. So I want you to always think about the splenic flexure as an area of profound ischemia because it's kind of a watershed area. And then another thing is the IMA also supplies most of the sigmoid and the rectum, but you also have another vessel that comes off the iliac that supplies parts of the distal rectum. And so sometimes around this recto-sigmoid junction, right, so we'll call this the recto-sigmoid kind of like junction area. This is another watershed area. It's supplied by the IMA, and this one's supplied by the iliac. Either way, in hypoperfusion, most blood vessels aren't perfusing tissues well. And so this is a susceptible area, and this is another area that can actually become hypoperfused and become ischemic. When these tissues become ischemic, it's usually on what side? The left side. And so oftentimes their pain is typical in the sense that they will present with two things. One is they'll present with usually a more classic left lower quadrant pain, but also they're causing lesions, especially in the rectosigmoid area. It's really easy for them to bleed. And so the other thing is that they'll also present with bloody stools, which we call hematochezia, because it's going to be more of a bright red blood. If a patient comes in and presents with abdominal pain out of proportion acutely and abruptly, acute mesenteric ischemia. If they come in, they present with postprandial abdominal pain, chronic mesenteric ischemia. They present with left lower quadrant pain and some bloodyish stools, you're thinking about ischemic colitis. If I said a patient has AFib, you think about which one? Definitely think about the actual acute mesenteric ischemia. If I said they have a very chronic history of atherosclerotic plaques, especially of multiple vessels, you're thinking about chronic mesenteric ischemia. And if I say that this patient's likely in shock and critically ill and now has left lower quadrant pain and hematochezia, you're thinking about ischemic colitis. Now, given all these facts, let's now talk about what are the potential complications of a patient experiencing prolonged bowel ischemia. All right, my friends, so now complications. If a patient comes in generally with the abdominal pain out of proportion to their physical exam, you're definitely thinking about acute mesenteric ischemia, and then start thinking about differentials, right? So start thinking about, is it thrombosis? Is it embolism? Is it hypoperfusion? Is it a venous occlusion? These are definitely things to start considering. I'd say one of the things that you have to be on high alert with, particularly with acute mesenteric ischemia, and that's why it's really one of the most terrifying ones, is this can really go downhill quick. Now, chronic mesenteric ischemia, I told you, they build collaterals. And oftentimes that collateralization of blood flow helps them to prevent from these complications that we're going to discuss. Ischemic colitis, it's usually hypoperfusion, so if you treat the underlying issue, oftentimes these patients won't progress to this. But ischemic colitis, to some small degree, can also potentially present like this. But I really want you to just focus on acute mesenteric ischemia. So with acute mesenteric ischemia, regardless of the cause, whether it's embolism, thrombosis, hypoperfusion, or venous occlusion, but the biggest ones, remember, is embolism and venous occlusion. Whenever this happens, we already know that it's going to cause a profound or massive, massive, massive decrease in O2 supply. And what we know is that if there is a massive decrease in O2 supply, this will start to induce ischemia of the bowel wall, right? So you're going to start to cause ischemia. Now, one of the big things is as these patients start to experience this profound, here, we'll actually do it like right here too, so we can make our diagram nice. Here, this is going to be profound ischemia because we're not giving blood supply here. Whenever these patients have profound ischemia, if it is not reversed in an appropriate amount of time, what will happen is you will increase, whenever you don't give oxygen to the tissues, they start to undergo what? Cellular hypoxia, they start to die, they start to necrose, it increases inflammation. And so one of the big things that'll start to happen is these patients will start to experience necrosis and infarction of the actual bowel wall. And once they start to do this, this is when they start to really, really, really go downhill. All right, so with profound ischemia that is not reversed, you'll start to institute necrosis and infarction to occur. When this develops, a couple different things happens. One is you lose your mucosal integrity. The mucosa is supposed to prevent things that naturally are in the bowel lumen, not from leaving the bowel lumen and getting into the bloodstream. So if things actually start to occur here, where things actually start coming into the blood supply because they have crossed the actual bowel lumen, now this is not good. So let's say for whatever reason, there's some bacteria, which are normally a part of your GI flora. These things are not supposed to cross over. But because there's a loss of mucosal integrity because of necrosis and infarction, they will. So now you're going to get what's called bacterial translocation. And then again, they're able to do this because the infarction, if you destroy this tissue and you cause massive inflammation, you cause increased capillary permeability, you cause destruction of the tissue, and now bacteria can just easily cross. When these bacteria translocate, this can allow for them to get easily right into the bloodstream. If these bad boys get into the bloodstream, what would you imagine could start to happen if you start developing profound bacteremia? Sepsis. And so oftentimes these patients can easily and quickly progress to one of the big complications, which is sepsis. And I think sepsis you want to watch out for in many different ways, right? Obviously watch out for fevers, increased white blood cell count, tachycardia, hypotension, etc. But I'd say the most concerning feature is if these patients have fever, leukocytosis, and also tachycardia, and then they go down the hill of shock. Then you're worried about septic shock, and these patients can easily and quickly die. The other concept here is that when bowel is dead, right, whenever there's tissue that's dead or it's super, super ischemic, you stop being able to perform aerobic cellular respiration. You know, you need oxygen to be able to allow for pyruvate to go into acetyl-CoA and etc. But if you don't have that, now you increase your anaerobic glycolysis. And so if you're increasing what's called, going back to all the old days, anaerobic glycolysis, what is one of those particular nasty molecules that causes a ton of problems? You guys remember? Lactic acid. And so when lactic acid builds up, you actually start having this accumulate a ton in the bloodstream, and it really makes this one specific molecule called lactate. And so lactate will build up and it'll get into the bloodstream because of increased anaerobic glycolysis. When lactate gets into the bloodstream, what is one thing that can actually happen? It makes your pH drop. When the pH starts to drop, one of the things that happens here is these patients start to experience an acidosis. And oftentimes that is more of a metabolic type of feature that we see. They maybe breathe a little bit faster, but it's more of a lab finding that we trend. And so you want to watch out for metabolic acidosis, because this could be a sign of true badness. It could be a sign of hypoperfusion, or it could be a sign of regional hypoperfusion, particularly to the bowel, okay? If I see these particular things, I'm really scared that the bowel has started to die and has started to infarct, all right, or it's profoundly ischemic. Let's say though, as the bowel wall becomes more and more ischemic and it begins to necrose and infarct, it's weak. And now we have increased the weakness of the bowel. As you make the bowel more weakening, so weakening of the bowel, we're just going to put increasing the weakening of the bowel. Now, as we weaken the bowel pretty profoundly, what happens is it becomes super fragile. And as it becomes super fragile, anything in this scenario, any increase in interluminal pressure can cause this puppy to perforate. And so one of the big concerns here is if these patients do experience perforation as a potential complication, how will they potentially present? So perforation of the bowel is pretty terrifying. When it does happen, any bacteria that hasn't already translocated can easily spread into the peritoneum. And so now you have bacteria going into the peritoneum. Bacteria spread to peritoneum. Now, when the bacteria spread to the peritoneum, what do you think is the potential complication here? It's going to cause inflammation and infection of the peritoneum. And as you start causing inflammation and making it super angry and infected, what do you think is going to happen? The pain is going to go up. And these patients will start to experience features of peritonitis. And so that's another thing that you want to watch out for, is an angry, infected, and inflamed peritoneum, which we call peritonitis. We talked about this in gastrointestinal perforation in other lectures, but peritonitis can present variable different ways, right? Oftentimes, it's these patients present with an intense abdominal pain, rigidity, guarding, decreased, rebound tenderness. And on top of that, they have features of systemic inflammation, increasing white blood cell count, fever. That's really, really terrifying. The other thing is bacteria can also spread into the bloodstream from the peritoneum. And so peritonitis can actually induce sepsis. And so that's another kind of interesting fact as well. So remember, sepsis can arise from these bacteria translocating across the necrotic bowel, or they infect the peritoneum and get into the bloodstream. The last thing that I think is also really helpful is that air will also leak into the peritoneum. And if you have air, which is naturally a part of our gut, if air leaks into the peritoneum, I think that's also relatively helpful. It may cause a little bit of distension of the abdomen, but one of the profound things that I think is helpful here whenever you get air into the peritoneum is it loves to sit just underneath the diaphragm, and that's a really helpful diagnostic tool on your x-rays. All right, so look for potentially a pneumoperitoneum. All right, and this may just cause a little bit of abdominal distension or more of a radiographic finding that could be suggestive. This is the big things that you need to watch out for. If a patient comes in with abdominal pain out of proportion and they start to present with peritoneal findings, now I'm concerned that they've perfed. If they present with septic findings and a metabolic acidosis, I'm concerned that they're translocating bacteria across that wall and they're causing a lot of anaerobic glycolysis. Now that we've talked about this, let's move into the diagnostic approach. We've gone through this a lot. I think the biggest thing now is to talk about, okay, how do I really differentiate if it's acute, if it's chronic, if it's, ischemic? A lot of it's clinical, context, but there is important things that you have to be able to discern here, which is not just, is it acute, is it chronic, or is it ischemic colitis, but also, especially in knowing a patient if they have acute mesenteric ischemia, is what's the cause? Is it embolic? Is it thrombotic? Is it a venous clot? Those are super important to be able to recognize. So let's say I have a patient with abdominal pain out of proportion, severe. They have a history of atrial fibrillation. And let's even say their lactate's elevated. I definitely think that it's acute mesenteric ischemia. They're having a small bowel ischemia.
So that suggests an acute mesenteric ischemia. All right, so what do I do? First thing I have to do is get a CT angiogram. And that CT angiogram will be beautiful, and any kind of angiogram is going to highlight the vessels, and it's going to show areas where there's kind of lack of filling. So you can see here that the blood is coming down, and then all of a sudden it's not filling as well through this portion here. Or you see that there's, again, a vessel here, and then it's not filling at this portion here. It's not filling at this portion here. So this is indicative that there is some type of clot that's occurring at some portion in these vessels that's reducing blood flow. And that definitely would help me to identify that this patient probably has either an embolic or thrombotic occlusion. The other thing with CT angiograms is that they can go during the venous phase. And if I look at the venous phase, I may be able to identify some type of like occlusion of the, not just the superior mesenteric artery as we can see here, but also an occlusion of like maybe the superior mesenteric vein. Either way, the CT angiogram is really good at being able to identify the clot, usually in the superior mesenteric artery or in the superior mesenteric vein, giving me the diagnosis, also helping me to determine my treatment. And a patient who presents with abdominal pain after having a meal, that postprandial abdominal pain, I definitely want to be thinking about chronic mesenteric ischemia, especially if they have a history that would suggest causes of athero, such as hypertension, hyperlipidemia, smoking. Those are all triggers for atherosclerosis. So I'm definitely thinking chronic mesenteric ischemia. So what would I do? I would get a CT angiogram. And one of the beautiful things about this is that it will show a lot of these vessels and where they're stenotic and where they're narrowed. And that'll help me to say, oh, this patient probably has some degree of chronic mesenteric ischemia. The last thing I want you guys to think about is, again, does the patient have left lower quadrant pain? Do they have hematochezia? And the reason why this is also important is it could help me to identify if the patient has ischemic colitis, right? Now, if the patient has the appropriate clinical context, they have severe shock, hypotension, they're on vasopressors, could be ischemic colitis. What would I do? Oftentimes, one of the tests is to get a CT of the abdomen and pelvis. And there's this terminology we refer to as the thumb printing sign, which shows a lot of bowel wall thickening here, especially in the portions of the splenic flexure and the rectosigmoid colon. The next thing is you could get a colonoscopy. And the reason why is the colonoscopy will be able to show these areas of infarct or lesions in those watershed areas of the rectosigmoid junction and the splenic flexure. And that would be diagnostic of ischemic colitis. So here we have an idea, again, if I think it's acute mesenteric ischemia or chronic mesenteric ischemia, get the CT angiogram. If it's multiple vessels and it's postprandial with history that's suggestive of athero, it's chronic mesenteric ischemia. If it's an acute onset, abrupt abdominal pain with a history of AFib, get a CT angio. Is there a clot in the superior mesenteric artery or the superior mesenteric vein? It's probably acute mesenteric ischemia. All right, let's talk about the treatment of intestinal ischemia. So it's really important that we identify patients who have intestinal ischemia. The first thing that we should do is bowel decompression. You're like, okay, what the heck? Why? Well, the reason why is if a patient has an ischemic bowel, the muscle is a part of that bowel wall, and the muscle is supposed to undergo contraction and propulsion and peristaltic activity to move food and fluids along. And if it's ischemic, it's not going to do that. And because of that, you can develop kind of features of a bowel obstruction. And so because of that, these patients could develop, abdominal pain, distension, nausea, vomiting. And because of that, you would like to decompress their bowel. So oftentimes we'll put an NG tube in, maybe suck some of the food and fluids out of that area to decompress the bowel and give it a break. Also, we'll try to prevent anything from going down through the oral cavity, give them a period of rest, and then replace any of the food and fluids that they vomited up or that they're not getting in because they're MPO by giving them IV fluids and repleting their vascular system. Another thing is that you can't let them become septic. If they start having a fever, they have white count that's really going up. On top of that, they're hypotensive. I'd be really scared if a patient has that and they have abdominal pain out of proportion with an increased lactate. I would start them on antibiotics. At least cover them from gram-negative rods, cover them for anaerobes. Usually, cefepime is an option. Another one could be piperacillin tazobactam, and another one could be meropenem. One of those three will cover all of those particular types of pathogens that are usually native to our GI flora. The other thing is if I have a clot in my superior mesenteric artery and my superior mesenteric vein, I don't want that thing to get bigger, because if it gets bigger in my superior mesenteric artery, I'll have more extension of ischemia. If it gets bigger in my superior mesenteric vein, I'll have more venous congestion and more extension of my ischemia in my small bowel as well. So I have to prevent that clot from getting any bigger. So a heparin infusion is usually going to be the quick way to go to, because you can turn it off and reverse it a lot easier than putting them on any other kind of anticoagulant. The next thing is I got to revascularize the bowel. And there's a bunch of different ways to do this. There's an endovascular technique or a surgical technique. So there's a lot of different things that you should remember with this. Now, there's grafts. We'll talk about this in a second. You can do stents. You can even go in and retrieve the clot, or you can literally go in surgically and cut out the clot. I think it's important to know when you do endovascular and when you do surgical, and what are the particular types of ways that you can do this. For endovascular studies, there's a couple of different things that you can do. If a patient has acute mesenteric ischemia without any evidence of massive bowel ischemia, so in other words, multiple parts of the bowel are not infarcted, or they have not perforated, you should do an endovascular retrieval of the clot. So in other words, you'll go find where the actual clot is. Let's say that this is the superior mesenteric artery and here's the clot. You'll go in and you'll try to retrieve that clot out of the area there. Sometimes they'll even come in and they'll squirt TPA in there to bust the clot up a little bit and see if they can pull the clot out that way. But that would be endovascular. Again, indications for that is no extensive bowel wall ischemia or infarction, and no perforation. All right. If they do have extensive bowel wall ischemia or infarction or perforation, or they failed endovascular retrieval of a clot, then you should go surgically. You'll open them up. You'll find the area where the clot is. You'll surgically pull that clot out. We call it a surgical embolectomy. And if they have infarcted areas of the bowel, you'll have to resect those infarcted areas of the bowel and then anastomose those ends. And then on top of that, if there's a perforation somewhere, you'll have to close off that hole within the actual small bowel. So surgical embolectomy, along with resection and then covering of the perforation in areas of massive ischemia, perforation, or failure of endovascular therapy. All right, we got some stuff over here like angioplasty, stents, grafts. When do we use these? Grafts are going to be more particularly used in chronic mesenteric ischemia. And this is especially when patients have like really long like plaques. Like let's say that this is the superior mesenteric artery and there's a plaque all the way down this length. This is not going to be something that's amenable to a angioplasty and stent. You have to completely bypass that area of extensive clot. And that's when a graft would be indicated. An angioplasty or stent is going to be more preferred in patients who have like very small areas of focal stenosis, usually in their superior mesenteric or inferior mesenteric artery. So we would go in where there's like kind of like this small little focal area of plaque. We'd inflate the balloon and then we'd lay in a stent for them to actually restore that normal flow to their bowel. There is another one that you can do called a endarterectomy, but usually we don't do that unless the patient is kind of not amenable to an angioplasty or stent, and we do it in more younger patients. But these are the ways that we would revascularize them. So again, it's supportive care to make sure that they have fluids and that they're kind of not having excessive nausea, vomiting, and abdominal pain, preventing them from becoming completely septic, preventing the clot from getting any bigger and worsening the bowel wall ischemia, and then improving the flow, whether that be endovascular or surgical, depending upon the indications. And if they have chronic mesenteric ischemia, determining a graft based upon a long clot, or angioplasty and stent for a focal clot. All right, my friends, that is covering intestinal ischemia. I hope it made sense. I hope that you guys did enjoy it. And as always, until next time.